First of all, I thank Dr. Saha for inviting me to give us such a talk here, panel discussion here. I'm coming here, returning back to City of Joy. I was here posted in Command Hospital here in Alipur from 2008 to 2012 as Associate Professor of Medicine and Medical Oncology here. Now coming to this topic, which is Oligo-metastatic NSCLC. That's the treatment paradigms or whatever the controversy is. So far, there have been excellent talks till now. And if you see, there has been some sort of a conclusion in these talks after going through all the trials. In this case, still we are in a preliminary stage only in most of the status. So whatever the panelists answer will be right. There is nothing called as wrong answer or anything in this. It's all we are in the early stage only. We are trying to pour in. And first of all, I wanted to tell you, I am not a subject expert in oligometastasis because hardly 5 or 10 cases only I've seen. So that first I have to confirm. Second, as far as the work is concerned, people would have read in this session, it's an attempt to take out as much information as possible. From my side, I'll be providing some information. I'll request the panelists to contribute to that. Okay. So let us proceed. Initially, because there are a lot of postgraduate students here, because this is a new topic which is getting introduced. Because already we know we are treating oligometastasis in colon, oligometastatic diseases in breast, now oligometastasis in lung cancer. What is the problem when compared to colon and breast? Lung, you have bilateral lung. You can have multicentric disease in the lung. Once we have multicentric disease, is it oligometastatic or is it multiple primary? That is a controversy, first of all, in the starting itself. So it's a difficult topic. We'll go through this and I may take some extra time because I have to cover so many things in this. So learning objective is, first of all, defining the oligometastatic, reviewing the underlying biology, exploring the imaging and staging, and analyze the evidence support of local ablative therapy. And I'm happy that all fields of oncology people are here so that they can contribute to the treatment aspect of this disease. And review the systemic therapy and integration of the local ablative therapy and discuss patient selection, controversies, and the future directions. So just for sake of our younger colleagues, this oligometastatic status was termed by Hellman and Viswanath in 1995. That was initially in 1995. From there, we are trying to define. Breast we have done, colon we have done, to some extent in melanoma we have done. Whenever it comes to a paired organ, we have difficulty in defining. Okay, so represent a transitional stage. Wherever we have, it's a transitional stage. Instead of becoming fully polymetastatic, it is this one. So I would request any one of the panel members if they can define the oligometastatic in NSCLC, because there's a lot of controversy in this because of their experience in the clinical field, if they can define any one of them.
So by definition, oligometastatic disease, as you have already mentioned, that it is the transition phase between the purely localized disease and the polymetastatic or systemic disease. So oligometastatic disease till date, as per definition, it should be, it can happen within, if there is presence of primary disease, it may happen so that there is primary disease is totally controlled. And after that, metastatic disease happens. Size-wise, the oligometastatic disease is defined as less than equal to 5 in number. And it can be metachronous or synchronous, means it can be coexistent with the primary disease, and it may happen that it can be diagnosed after the primary disease has been controlled or cured.
Yeah, I fully agree with you, madam. Because now there's
I just want to add here, like it's actually, if you see actual definition, oligometastatic disease is one of my pet subjects. That's why I wanted to pitch in here. So it's an intermediate state, because understanding oligometastatic disease is a thought process rather than the actual process. It's an intermediate state between curative to palliative. So what we call it as actually, there is no the terminology to be used as a definitive treatment. So it's an intermediate state where there is the sweet spot where you can get a curative intent of this particular patient. It depends on the primary and depends on the metastatic disease. either the treatment is given, it may be asynchronous, metachronous, or it depends on the histopathology, depends on the number of sites, number of organ, or the actual definition right now, we are talking about up to 5 lesions, maybe multiple, or in the same organ, or up to more than 3 organs.
Excellent. Because
just
both of
one more thing, sir, I want to add. Everybody has
I'm
mentioned
really excited with the interest shown by everybody.
number, but those lesions should be amenable for local treatment.
Exactly.
That is the, I mean, it should be included in the definition.
About that one.
Yeah.
Exactly. That's true. Yeah. So, as all our panelists have already told that this is the thing, 1 to 5 matters. This is again a consensus only. We don't have any data specifying that this is the exact thing. There has been a range between 3 and 5. Generally, now this is 5, which is told in radiotherapy oncology astro guidelines, which was published in 2020. Now, the spectrum of metastasis. Already as described, there's a lot of spectrum of metastasis. Whether it is localized, that is usually no, we don't call it as metastasis. Then oligometastatic disease as already described, whether it is synchronous, metachronous, or induced oligometastasis. That is, already patient has a metastatic disease. You give chemotherapy, some areas respond, some areas do not respond. You induce it into oligometastatic state. Then you have polymetastatic state and the implication of treatment approach and diagnosis. Now, these are all same thing which all of them have already discussed. It has made me my work easier so that I can skip through all these slides faster. And again, this is the astro guidelines, less than 5 metastases, less than 3 organs. Now, epidemiology, around we see 30 to 50% of the NSCLC cases are metastatic, even in our setup also. Oligometastatic disease, among this, around 20% will be oligometastatic. It is our effort or endeavor to catch this 20% of the patient who can be given a definitive treatment. That's the aim of this. This is driven by improved imaging, molecular diagnostics, and multidisciplinary approach. Now, biological basis of oligometastasis. Anybody can take this question because all of us are quite new to this topic. All of us are in the same boat. So anybody who is interested can answer this.
The biological basis is actually, if you can see, the intent of treatment from where we are talking about can like only immunotherapy can replace surgery. Answer is it's a hard yes. It is happening in the same way. In an oligometastatic disease, can we intend is to go for a curative intent? Yes, it is possible with a multimodality approach. That is what the biological basis, where the seed and salt theory, there are different types of theories where the primary may go into the same type of cells or depending on the genomic testings, like genomic guided treatment may guide us better. So that's mainly the biological basis.
So if you see biology of oligometastasis, is it upfront oligometastatic or is it upfront systemic? There are two. These are all postulates which are coming up. Or is it transferring from initially which was oligometastatic and gets converted into polymetastatic? So this is all still in a very, very preliminary stage. We'll be speaking few aspects of these things because we all know tumor cell is in evolution. It's an evolution of cells in our body and survival of the fittest, which is the biology of any tumor. So is it stage migrating from a localized disease to oligometastatic to polymetastatic? Are we trying to catch the patient in that oligometastatic stage? The biological basis of oligometastasis has already been described. Distinct genomic and transcriptomic profiles and proteomic profiles. These are all under investigation. Few results which are there, which we will be discussing about. Then slower growth rate, limited metastatic potential. Why there is a limited metastatic potential, that also will speak. Then favorable tumor immune response. Now, molecular characteristics. If our molecular specialists, if we can contribute to that, because I'm very happy that there's one panelist with molecular this one, because it's a difficult topic to understand most of the time.
So traditionally we've been doing EGFR, ALK, ROS, RET, MET, and now we have other biomarkers as well. So as in the laboratory, we don't get to know that this is an oligometastatic lesion,
exactly.
or there is a what is the stage in which we are receiving. We receive the biopsy and we tend to kind of characterize in that aspect. So, but in terms, if we get a biomarker and what is the rationale and what interpretation and how you're going to treat, that may vary. That may vary with even if we get a BRAF mutated cancer or an, so that if we are getting that, so whether the treatment is going to change or not, or if you are, how you are going to manage on that, so that aspect.
So this is again, we are coming back to the question that we have to do NGS in as many cases as possible, because once we start getting the data, we can be able to assess and prognosticate whether this oligometastatic will progress to polymetastatic or whether it will stay back in the oligometastatic state for some time. So fewer mutations and CNVs, then enrichment of the immune surveillance pathway, then ongoing search for predictive biomarkers, which we'll again speak later. Now, there are some microRNA data profiling which are shown expressly to characterize the oligometastatic states. So, unique microRNA signatures differentiate oligo versus polymetastatic phenotype. These are all under trials. These are all initial trials where microRNA 200C and microRNA 328 have been found to tell that it retains the cell, oligometastatic state. As far as microRNA 200C is concerned, if it is present in the primary, that's why the importance of doing, in this we want to do the molecular profiling in the metastatic lesion. If you do it in the primary lesion, if there is a microRNA 200C enhancement, then it shows it has a metastatic potential. But if it is done in the metastatic side, and if there is an increase of microRNA 200C, then the patient will tend to be in a oligometastatic state for some time. So this controversy or dichotomy is there. So what we have to do is further, essentially needing further trials are awaited. So molecular signatures, as far as colorectal and renal cancer, we know this real thing. But as far as lung cancer is concerned, we still do not know. So immune landscape, anybody can just contribute to this, please. Immune landscape in oligometastatic disease. What do you expect it to be? Because we still do not know. Whatever you tell, because of your experience and understanding, we have to take. We still not know what would be the immune landscape of this type of diseases.
You mean hot and cold? One? Most of the lung cancers with the metastatic disease will be immuno responsive or a hot tumor.
Yeah, exactly.
So that's one of the things what we have observed.
So they have higher CD8 positive cells infiltration. That means there is a Tregs are relatively less. So when Tregs are relatively less, the effect of PD-L1 will be much better in these cases if they are PD-L1 positive, or nowadays, irrespective of the PD-L1 status, we are using immune checkpoint inhibitors, they will respond better. Then better response to immunotherapy, which already I was mentioning. Then ongoing studies integrate immunogenic profiling also, immunogenomic profiling. Now, imaging in oligometastatic NSCLC. Any of people who can contribute to this? What are the advances which has helped us?
So, for imaging, I think first, after CT scan or whatever the primary imaging, if we are suspecting that it is a oligometastatic disease, then whole body PET CT scan and MRI brain, I should advise. I usually advise. And if there is metastasis to the spine or liver, then I will also add MRI spine or MRI liver.
Yeah, so here in oligometastatic NSCLC, as you were saying, that how we can differentiate between a polymetastatic clone and a oligometastatic clone. So there are some studies which have shown that the SUV uptake in PET CT scan can be a surrogate for deciding whether this is an oligometastatic or a polymetastatic disease. So in this, I think in and there is also a stage migration. So many stage 3 get converted to stage 4 by using functional scan. So in this situation, I think functional scan might become handy to us.
Yeah, functional scan definitely has improved the outcome.
PET, any lung cancer, whatever the stage is there, PET scan is mandatory. That's what I'm telling. And MRI brain and spine is also mandatory, because we always see the metastasis 2 steps ahead of that, where the chances is going to be there, it is to be included. Even for the same, even in follow-up, because it's an A to A comparison. It should not be like that. Numbers and the volumes has to be numbered in metastatic disease in NSCLC, because I would like to underline, we wanted to going for a curative intent.
That's the thing. It's the main thing is
And
intent.
also there should be comparison with the previous scan before the systemic.
Yeah.
That should be always there.
See, generally when a patient comes with metastatic CL lung, unless and until he is having CNS symptoms, we don't get a MRI of the brain done. But when you are suspecting a oligometastatic, it is better to do a MRI scan of the brain. That will pick up any metastasis, and PET scan definitely improves. And not only this PET, now you have bone scan and MRI are also, as the doctor was mentioning, it has improved our understanding of the extent of the disease. And importance of comprehensive baseline assessment is very important, because whether we'll be able to do ablative therapy to the metastasis and also to the primary, that needs to be assessed. Otherwise, it's not useful speaking all those things here. So now advances in imaging tools. Now radiomics for risk classification. With the advent of artificial imaging, the radiomics, which we call, in fact, they are telling that the latest deep learning technique, which tells whether from the pathological slide, this one can pick up whether it is responsive to immune checkpoint inhibitors. To such an extent it has come. These are all still in phase 2 trials. They have still not been approved by any societies. No phase 3 trial is there. They are just going on. The spectrum of oligometastatic disease. So if you can, anybody can add on this?
Oligometastatic disease, the metastasis can be in brain, adrenal, and in other sites like liver or bone. That's all. And non-regional nodal metastasis also.
In fact, what ma'am was saying was exactly right, because depending upon the location, the method of assessing the local ablative therapy differs. These are all again in phase 2 trials only, where they have used this. So spectrum of oligometastatic, there's a consensus recommendation. If you see here, you have 9, all these highlighted by color. They are the 9 various types of oligometastatic states, whether it is oligometastatic synchronous, oligometastatic metachronous, oligoprogressive, oligopersistent, resistant. All these 9 states are there. Depending on it, depending on this state, we have to plan our treatment. Now, when we see this, the whole discussion itself looking perplexed. But actually now we have data only, that to phase 2 data only in synchronous oligometastatic states. We don't have any data in any of other states as of now. So it is such a large topic. Why I'm stressing it is, a lot of youngsters are there. They can take up research on this. They can take it as the thesis topic also, if they can collect so many cases, and it will be one of the earliest publication from Indian side. Now, classification based on disease, you have de novo synchronous, then oligo-recurrence, oligo-progressive, oligo-persistent, which are the broad classification. Now, this is all a dynamic model. We wanted to test whether that disease progress from localized to oligometastatic, from oligometastatic to polymetastatic. So this OligoCare prospective cohort trial is recruiting cases. In another 3 or 4 years, we'll be able to know what would be the outcome, what would be the biology of this disease. The staging consideration, already all the speakers have told that even in N2 has been further divided, and mainly metastatic. We are speaking about metastatic. Till now, they were speaking about non-metastatic states. Main metastatic itself, now it is M1A, M1B, M1C. So this is, we are speaking mainly about M1A. This oligometastatic mainly come in this M1A. If it is M1A, we can still try a curative attempt in these patients. In around 15 to 30% of the patients who can have a long-term survival. Rest of the patient, they can have oligopersistent or oligo-recurrent or oligo-progressive. In such cases, further modalities of treatment can be added. The treatment overview. So anybody can add from their respective specialties about the treatment overview in these cases.
Yeah, I mean, in oligomets, we have an option of local therapy. What also I would like to add is that it is important to know the mediastinal lymph nodal status before starting treatment for oligometastatic. So there comes a role of US or EBUS to understand if the patient has a N1 or N2 disease. because that also would reflect into the prognosis. And of course, treatment options would depend on several factors like site, size, disease-free interval. So many associated factors are there. Yeah.
Anything, madam, from your side?
After confirmation of oligometastatic disease, as medical oncologist, I will send the ISC and the molecular testing, NGS and PDL1 by ISC for determining the further treatment, systemic treatment.
See, now we know the.
May I add something?
Yes.
Yeah, so I mean, treatment for oligometastatic disease actually, when it is established that it's a oligometastatic disease, then it will definitely a multidisciplinary approach. And first, we have to assess the disease and the symptom. If there is any local symptom for metastasis, then that should be addressed first. If it is a brain metastasis or spinal cord compression and that is causing symptom, that should be addressed first, followed by, I think, systemic therapy for sometimes 3 to 6 months. Then again, we have to think about the other metastatic site we have to take care of. I think, I mean, it's definitely a multidisciplinary approach, but this should be.
I want to add something that there is some guideline, AstroHisto guideline published in 2022. So exactly this approach that first you
will be coming to that.
Yeah. If any symptomatic lesion, then you address it. Then you add the systemic therapy because it is ultimately oligometastatic. You assess the response, then you go for the local therapy.
Yeah.
Also, I want to emphasize that as we are discussing oligometastasis, so oligometastatic disease, somehow our treatment intent is sometimes curative. So if it is possible to treat the oligometastatic sites with local radiation, high dose radiation or SBRT, that can give a good systemic treatment free interval to the patients also. So that is also important.
So oligometastatic disease are metastatic disease. So systemic therapy has to be given. That's given. Now the question is when we are addressing whether we are going to give local therapy or not, be it radiotherapy or surgery. In that case, the aggressiveness of the tumor needs to be taken into consideration. For example, a very rapidly progressing, even the number are less, but the disease has progressed very fast. Let's say some sort of bad molecular signatures like KEAP1 or STK11 in the biopsy. These are the issues which we have to consider before deciding whether we are going to go for local therapy or not, because there are time and again, we also have to see whether we have so good systemic therapy or not, where even there might not be any need for local therapy. So these are the various considerations we have to take into mind.
Yeah, absolutely agreed with all your points. It's no this one.
One small thing I want to consider, specifically for M1A disease, we need to understand if it's a oligometastatic disease or a second primary.
Yeah, that's what. That I'll be coming to that. See, the thing is, standard is systemic therapy as a foundation. Now, when to start the local therapy, local ablative therapy? As every panelist was mentioning, it depends upon the clinical condition. If the patient has a fracture or a spinal involvement or a raised intracranial tension, that needs to be addressed first before starting on systemic therapy. We don't have any data on that. We have only phase 1 data on that. It's all evolving. That's why I was telling this has to be discussed in a multidisciplinary board. It's something like a multidisciplinary board we are having, and this has to be a case-by-case discussion. But if the patient is not severely symptomatic, except for that initial no localized symptom causing severe disease, then systemic therapy you start, give 3 months of systemic therapy. Why is 3 months? Some studies tell 3 months, some studies tell 6 months. Basic is 3 months because biology of the tumor, doubling time of the tumor is around 3 months in any solid tumor. You give for 3 months, then plan, assess and plan for local ablative therapy, either surgery or radiotherapy. Consolidate the response, and multimodality strategy is very key. Systemic therapy options, these are all the various systemic therapy options which we have. Targeted therapies, again, extensively it has been spoken. Role of
Viswanath, your time is up, so you can cut short.
Yeah, that's what. I'll just go through. Radiotherapy is complete. Now, what I wanted to emphasize, one is surgery. Another one is SBRT is coming in a big way in management of this local oligometastasis, where they can give a very good, effective local ablative doses. These are all, most of them did not, they are all only phase 1 studies. Just for mentioning Sheikh, I mentioned. Then ongoing trials.
I think you should give 2 more minutes to us because we are just starting the SBRT.
So SBRT Comet trial, again, it has shown that.
I've come all the way for only for 2 hours. Okay.
Okay, you got 2 minutes.
I'm really happy that it has created so much of interest.
Yeah, actually.
See, histology agonistic phase 2 RCT, SAB, this one SABR with standard palliative care. This has shown when you use a local therapy, it definitely improves the overall survival and progression-free survival. Then this NRG to lung 002 trial, again primary results are pending. Then ongoing planned trials. These are all the 3 planned trials. Not only this I could lay my hand on. There are further trials which are going on, which at present it may come up further. Then patient selection, as everybody was mentioning from the beginning, that is very important. So I request the panelists to tell more brief.
Yeah, I'll take 30 seconds because they're closing down. So SBRT for lung, especially oligometastatic disease, I'm doing for 2011 onwards. It's almost 16 years where Comet trial started. Before that, we are doing it. Whole concept is, the controversies is when to start, what is local treatment, and what we are talking about. The same thing we are talking for last 15 years.
15 years.
So like either to treat primary or the only metastatic disease, symptomatic, asymptomatic, or immunotherapy first or other things first. These are the controversies. We are starting with the systemic, you told synchronous metastatic disease. That is, see a lung with probably operable less than 4 centimeters or 5 centimeters with a single metastasis in the brain. No controversy here. We can treat both. So it left to the doctor to consider either immunoguided or any of the molecular targeted guided. In these cases, yes, there's no need to hurry up for the SBRT. We can go ahead and give the molecular treatment, directed treatment. There's no need to hurry about that. But you have a timeline, 3 months, 6 months. Reassess them actually according to the point of time, and don't hesitate to send it to radiation oncologist to come for SBRT. So that is one. And treat as much as possible all oligometastatic sites. It is possible now with the newer techniques. I do with CyberKnife. I've done only for brain up to 22 lesions, only SBRT 5 fractions, only the brain lesions. Number is not a problem. Volume is an issue. The same with the lung and the mediastinal nodes can be treated. Metastatic diseases up to 5 to 6 lesions is not an issue. We can go and treat. Local control is in the range of more than 95 to 98%. So we have done our study also. We are going to publish that. So metastatic directed therapy is the terminology what we use it. It has to be considered as and when required without hesitant. It does not matter. Lung cancer has to go to a double digit of survival. Oligosynchronous, oligometastatic, it's persistent or residual, or it may be recurrent isolated. All the places SBRT plays a role. So when to do it, it depends on you.
So in fact, he was telling about 22 lesions being treated. It's true because we have seen in osteosarcoma, we have been treating so many multiple metastases. Then there was, everything has been done.
Another thing is in the SBRT in oligometastatic, I'm using immunotherapy along with SBRT. That is day 1 immunotherapy because SBRT enhances the immunomodulatory effect and acts as an abscopal and the other systemic effects.
Astro 2002 guidelines algorithms which I'm doing. These are all these slides are in public.
Sir, we have to conclude here.
Yeah.
Sir, we have to conclude the session.
We have concluded.
Thank you all the panelists for their excellent participation, and thanks to the moderator, Dr. Viswanath, for your excellent preparation of the topic. Really, it is a vast topic, and it is not very much possible to encompass all the issues in one panel. Anyway, thank you a lot.
Thank you. Can you have a group photo?